Good morning, respected friends. I'm Dr. Ragini Parekh. We have a course on Phacoemulsification, which is a case-based learning. With me is my teacher and mentor, Padma Shri Dr. Lahane sir, Dr. Sirish Thorat, who is the president of the Maharashtra Ophthalmological Society, Dr. Navneet Toshniwal, who is a very good innovator. And we start with a guest talk by Dr. Jebin Brahim. He is a prolific cataract surgeon from Arvind, and you all know that Arvind, the systems have a huge load of cataract surgery, so he's the guest lecturer, and I think we can start with him. Good morning, friends, and thank you all for being here today. And if you have any questions or if you have any tips for us, they are all welcome. This course is about phacoemulsification, which is now the preferred technique for cataract surgery today. And as we progress with the course, we can discuss more and more. Dr.
I will invite Jebinath Barayan. He is a cataract surgeon from Arvind, and he has a guest lecture. So, request you to go ahead.
Thank you, sir. Thank you for giving me this opportunity. Wishing all a pleasant morning. And as ophthalmologists, we should take the pride that we belong to the sector of medical fraternity that boasts one of the most commonly performed surgeries worldwide. The commonality may mask our days, but remember, each eye is unique, but so each patients are. So I'm here to tell certain special situations which defy the deployment of conventional cataract surgery. Be it a middle-aged security left crippled by life-changing accident, or an 8-year-old fragile wheelchair-bound nighty-called party afflicted with hemiplegia, or a 70-year-old gentleman severely skyforced but shouldering years of wisdom. The stories may be plenty, yet it all, we could see their gleaming eyes holding unflattering hopes of brighter tomorrow. Their physical condition or grave systemic comorbidities have served as an hindrance for them to receive quality eye care at several places before they presented to us. But their indomitable spirit of not giving up what may propelled us not to give them on us. So in search of literature revealed that options such as face-to-face emulsification using slit lamp and face-to-face phaco in a semi-reclined position and operating in a motorized wheelchair. But operating in a center which caters predominantly to the people from humble background, these sophisticated options were out of question, and we at Arvind have always believed in delivering quality eye care which is affordable to all. After much deliberation, the idea of PhacoSit, a novel 90-degree sitting phacoemulsification, was conceived using only available resources, a simple plastic chair or a wheelchair and an adjustable microscope. We have published this technique, innovative technique, in the Indian Journal of Ophthalmology in the year 2021. The process involves this following step. A sterile surgical drape was plastered in one side of the OT wall. To maintain asepsis, our patient is made to sit comfortably on a wheelchair or a plastic chair with their hands, head and cushion comfortably with pillows. Vitals were monitored with sphygmomanometer in one arm and pulse oximeter in other arm. After thorough skin preparation, another drape is used to cover the face and trunk, and it taped to the edges of the drape which is in the wall. The lids were kept open with speculum, and a drain punch was fixed inferiorly. The operating microscope was set at an angle of 70 to 80 degrees from the vertical plane. The surgeon sat at a height adjustable chair facing the patient upright in erect position. Meniere's disease may pose seeming innocuous condition, but you wouldn't believe, I told one of our patients was taken on table 3 times at different hospitals. But each time the surgery has been cancelled due to distressing systemic manifestation, the patient finally presented to us with hand movements in one eye and 2/60 vision in other eye. I opted to proceed with Phacosit for her. The left eye surgery was planned first. An inferior temporal self-sealing 2.8 clear corneal incision was made at 4 o'clock, and 1 mm side port was made at 7 o'clock. The only requirement from the patient that he or she shouldn't tilt, turn, or move the head forward. After staining the anterior capsule with trypan blue, adequate size capsular excess is done under OVD cover. Actually, in Phacosit, that the Phaco parameters we don't have to change. We can use the same parameters which we use for the regular routine Phacoemulsification. We have done it in supine position. After good hydrodissection, the nucleus is rotated, and high molecular weight OVD is used to protect the corneal endothelium, and I prefer to do a direct chop technique in this patient. A straight chopper, vertical chopping is done. Almost 6 to 8 pieces are done. The only downside is that the surgeon has to operate with an outstretched arm, so prolonged surgical duration could lead to fatigue. Hence, I wouldn't recommend this for the novice surgeon to attempt this. So carefully the quadrants are emulsified one by one, taking care not to damage the corneal endothelium and also the posterior capsule. After removing all the quadrants, I used a coaxial IA to aspirate the cortex, and then forming the antechamber with visco. A single piece foldable IOL was injected and placed inside the bag. A thorough wash was given, and the antechamber is formed. But the right eye added to another level of complexity. As you see here, is having high astigmatism. So after calculating for an inferior nasal clear corneal incision, we opted to proceed with toric IOL placement for this in the right eye. The surgical steps for the toric marking part, other than the toric marking part, was same as we see in the last surgery. You may observe that both of the eyes were in advanced stage of cataract. This is in majority of the case of these Phacosit patients, because as they either have delayed seeking care due to their physical inability or were turned down due to multiple places before they reach on to us. The one tip I would add here is, like, you can make the additional bend in the tip of the cannula, the hydrocannula, so in the shape of U, which will be very helpful, easy in hydrating the corneal wound at the end. A special study was conducted to analyze the operative outcomes of this Phacosit patient. So far, I have performed more than 60 eyes, but the results of the first 33 were analyzed. All through the course of surgery, the patients maintained stable vitals, and highlights that our patients were comfortable and stable throughout the procedure. The average surgical duration was 10.37 minutes, and the average CD was 12.22. The average surgical duration in the left eye was less compared to that of the right eye. Right eye have a high significant CDE values because of the nasal bridge acts as a difficult factor in doing right eye surgery. The testimonial from our patients serves as a positive testament to the efficacy and the comfort of this technique to our patients. The radiant smile adoring the faces of our patients highlights difficult roads often leads to beautiful destination. Thank you.
Thank you very much, Jagannath. I think, as you know, the Arvind is doing very good work. अपना computer है उधर. IT person, please come.
Thank you, thank you.
So the IT. So the you have seen the Jabinath, what type of patient he is operating. So like that, we are also doing the cataract in the leprosy in the Baba Amte's ashram, and so it is very difficult whenever you go for such type of.
ऑडियो नहीं, वीडियो है. वीडियो है, लगा दीजिए.
All right. So I invite Dr. Ragini Parekh. She has single-handedly performed 85,000 cataract surgery, maybe highest done by any woman in the India and abroad. She is an excellent SICS and Phaco surgeon, and now she is the chief of Manorama Hospital in the Mulund, Mumbai. So she is going to talk to us about the tip and tips of the soft and posterior polar cataract.
This is not moving. Somebody can help me? I'm not getting to the slideshow. Yeah, thank you sir, thank you everybody. Good morning friends. थोड़ा लाइट कम कर देंगे. So I have no financial interest. As you can see that if you have a soft cataract, the glow is very good, but it is important to have a good rhexis. The hydro procedure that you do, you have a small point hydro procedure, because if you have a posterior polar cataract, it may be difficult. So you need to have a good hydro procedure and a good separation of the nucleus. As you can see, when you emulsify the nucleus is very, very soft, and you have to use low parameters. You have to be very careful that when you do a stop and chop, here the cataract looked very soft, but it is a grade 1, grade 2, so it could be
light come kar do, please.
So that my video can be seen better if the light is a little less.
Stage ka light bhi kam kar do.
As you can see, this is a stop and chop procedure where easily the pieces were made, the first division, and now the quadrant removal. So this is a comparatively easy soft cataract where a stop and chop technique was able to be performed to do a successful phacoemulsification. And now if you see, this is the second case where this is an extremely soft cataract, and you have to, the whole cataract will be difficult to be stopped and chopped, and it is so soft that what you do is you remove the cataract as a whole and you flip or make a nuclear solute, and then it can be emulsified easily. Very low parameters or only with the aspiration it can be removed. So different techniques are used. This is the epinucleus mode where the epinucleus plate was there to help you. This is a posterior polar cataract where only hydro delineation is done. Hydro dissection is not done because you are scared whether there will be a posterior capsular tear. And you try again to emulsify the nucleus. We think that the soft cataracts are very easy when we start surgery, but as you do more and more surgeries, you realize that they are not only very easy, they can turn out to be extremely difficult at times, and you attempt to do stop and chop here, but you are unable to divide this, and the saucering occurs. Because the cataract is so soft, with every trench there is a gutter into the nucleus, and you may be unable to divide it. but you have to be patient, and then if you can take one piece and rotate it gently. Here you have to be extremely careful because the posterior polar cataract, there may be either a frank dehiscence or there may be a attenuation which by your techniques or wrong fluidics can extend into a tear. This is the epinucleus which remained because we did only hydrodelineation, and in the epinuclear mode this cataract, the epinucleus is successfully removed. We use the AC maintainer and the Dr. Lahane single port cannula for complete removal of the cortex. Any method by which cortex can be aspirated, may be mechanical or using irrigation aspiration, can be used to do a successful IA. So that's very, very important. So in a cataract, these are the various techniques that you use. Here, this is again a soft cataract where the rhexis is very easy to make, but you have to be careful because if you break the commitment to rhexis, you break the commitment to phacoemulsification. If one is unsure, then even dye-assisted rhexis can be done. In any phacoemulsification, the hydro procedure remains very, very important because it helps to give you a free nucleus and an epinuclear buttress. As you can see over here, this is the nuclear salute, which actually helps you to cartwheel the nucleus and bring it anteriorly. Here one has to be only careful that you have to use a good viscoelastic to protect the corneal endothelium. As you can see over here, it is going to be impossible to stop and chop this nucleus, but because we have a free nucleus with a good hydro procedure, with a solute and a good followability. So what is important here is a good followability, which means that the ability of the probe to hold the nucleus piece to itself, and if keeping the probe central, you do not have to go and fish anywhere in the periphery. The nucleus comes to you and it can be emulsified. It is very important to be central because otherwise there will be a PC tear. Stop and chop, as you know, it can be done. If the nucleus permits stop and chop, a good rhexis, a good glow are the benefits in these type of soft cataracts, and the rhexis helps you because it keeps you safe. Now here, as you can see, that the glow was very good, but the cataract is a grade 2 cataract and it is hard enough to be emulsified by the standard stop and chop technique, as you can see over here. So you make a trench and deepen it to make a first division, as you can see over here, and then go ahead with the standard stop and chop technique. So these are the various techniques of phacoemulsification in a soft cataract. You have to choose the technique as you go. You have to assess the cataract, understanding how soft or hard it is. As you can see over here, this is the first quadrant removal and now the second. Then rotating the cataract piece towards you to emulsify it, and as you can see that this free nucleus helps you do a good phacoemulsification in that plane without being in the iris plane or above, protecting the corneal endothelium. The chopper assists to bring the nucleus pieces to the probe, and please note that the probe always remains central, which is important in any cataract, but even more so in a soft cataract because the periphery would be even softer than the center, and inadvertently there would be a PC tear. So there are multiple ways and techniques to manage a soft cataract. As we saw, the solute, the removal of the complete nucleus, stop and chop. And basically what is important is, and what I want to stress here is not to leave the safe zone for phacoemulsification. The safe zone is the circle within the rhexis, and maintaining an anterior chamber, a good phacoemulsification machine with good fluidics which maintain the anterior chamber without any surge is extremely important. Since the cataract is very, very soft, the parameters that we use here would be very low. That means ultrasound would be very low, but your aspiration would play an important role in doing most of the work, and that is very, very important. So one has to remember that this is extremely important. This is another video where you can see that the cataract is extremely soft, and hence forceps are used to do a rhexis. You can use anything. This is a younger patient where the capsule would be more elastic, and hence, the use of the Utratas forceps. Whatever you use, it is very important that the rhexis is complete and is not broken, because that is the first step towards a successful phacoemulsification. One can see very clearly over here that it is a posterior polar cataract and the capsule is extremely elastic. Hydrodelineation and not hydrodissection is very, very important. Multiple points of hydro procedure, as you can see over here, not concentrating the fluid and aspirating it in such a way that the nucleus is aspirated completely. So one more soft cataract case, as we can see over here. You've already seen some techniques, some more videos that I would like to show if the time permits.
Yes, yes, go ahead.
Okay. So we saw the various techniques and some more videos where you will see the flip, the bowl technique, or the stop and chop. This is a case of a posterior polar cataract once again. Since our course is a case-based technique, we can see multiple videos. As you can see, the golden ring, but multiple small points of hydro, very difficult to chop. So to solute or to carousel this nucleus and bring it anteriorly, and to cartwheel it, as you can see over here, and flipping the nucleus, as we call it, and removing it. This epinucleus piece can be easily dealt with later on, either with the irrigation aspiration. Now, actually, you don't try to do a bowl technique. What actually happens in a soft cataract is that when you try to do phacoemulsification, there is a crater effect. The cataract is so soft that every trench results in almost 2/3 of the nucleus being trenched, and this is something which is not very, very desirable, because then you cannot handle it. So the best thing over here would be to flip it or to make it solute. Sometimes if you are not able to do anything over here and a saucer is formed, you can wait, put visco, separate it again with a little bit of hydro, make it loose, flip it up, as you can see. So this is the most desirable or the most comfortable technique, by flipping the nucleus or making a solute and using more aspiration than phacoemulsification. The epinucleus buttress definitely helps to protect the posterior capsule and also the posterior polar plaque, which can be seen. Again, where you can see multiple hydro procedures with multiplanar hydro dissection can be seen. As you can see over here, this is extremely important to avoid the fluid overload at one place and separation of the nucleus or the nucleus solute. So as you can see, these videos are so beautiful, and luckily we are able to show it, and removing the nucleus as a whole. So we feel that soft cataracts are very, very easy, but they are not, but they can be tackled, and the epinuclear buttress always helps. So here only aspiration is used. You don't need to use any ultrasound. And then removing this epinucleus in the epinuclear mode. So this is also very, very important to use this, to use blunt choppers, because you don't want to pierce the PC at any point in time. So what is difficult is there is no grip of the nucleus, it is difficult to chop. There can be an unstable anterior chamber and an unstable posterior capsule. They invite capsular rupture. There may be a frank attenuation, as you can see, and these are signs of caution. You have to be very, very careful, because you have to counsel these patients because they are very, very young, and you have to have a posterior segment ready. So a good rhexis, hydrodissection free phaco, as we saw, low vacuum, low inflow, low aspiration, which are very, very important. So thank you, friends, for all the support and by being here. And if you have any tips to give us or any advice, it's always welcome. Thank you so much.
Thank you, Dr. Ragini. And now I will call upon, it was a, I think, soft cataract. Ragini is a master in the soft cataract, because I never do it.
Yes, sir, because I was always cheating and I sent all the hard cataracts to Sir's
Now
table.
I will call upon Dr. Sirish Thorat. He is going to speak to us about the subluxated cataract. Dr. Sirish Thorat is from Akola. Very good phacosurgeon. When I say very good means he is very good phacosurgeon. And now in this year he is a president of Maharashtra Ophthalmic Association. Yes, Sirish, go ahead.
Sorry. Can you help me?
कुठला
Here?
लोडेड आहे ना तुझा हे कुठं आहे हां ना हां ठीक आहे ओके 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 IT person please help हां good.
Good morning all. At the outset, let me thank Dr. Ragini Madam for including me in the team. Friends, today cataract surgery is like refractive surgery.
Light reduced by okay.
And what are the types of cataracts, whether it is posterior polar, subluxated, patient want your 100%. So cataract surgery in subluxated cataract poses many challenges, right from getting a proper rhexis to the long-term stability of the IOL. Broadly, we can divide subluxation into three categories like mild, moderate and severe. Mild can be get tackled with the 3-piece IOL plus CTR. Moderate, which is below 120 degree, must need CTR plus 3-piece IOL, and severe cases of subluxation must need scleral fixation device. So this slide is important. If the zonular weakness is static, like in traumatic, congenital or colubomatous cataract, fix the bag, and if it is progressive, you need to fix the IOL, like in a cases of pseudoexfoliation. These are the different devices used for scleral fixations. There are many more. So we'll directly jump to the case-based presentation. This is a case 1 with a coloboma more than 90 degree of subluxation. These are my planning. The rhexis in such cases is very difficult task. Always start the rhexis away from the area of zonal dialysis, that is exactly 180 degree from away from the dialysis. Go slowly in the area of the zonular weakness and purposefully decenter it toward the strong zonules, so that when you pull the back into the center, it will get good rhexis in the center. Capsular hook is the main device in such situation, and this is life saving. Slow motion phaco is indicated in all such cases. I usually prefer direct chop technique, and while removing the cortex, pull is toward the area of the zonal dialysis, that is toward the red glow. So epinucleus and cortex is getting removed. I have removed the capsular hooks. If any vitreous strands, if you are suspecting, then you can tackle at this point also. CTR is getting injected. Important is take out all forces of CTR on the Sinskey's hook or any blunt instrument from the side port, or you can use the injector. I was suspecting some vitreous strands in the lower quadrant, so I am just confirming with the triamcinolone and getting it cut by the vitrector. Once it is done, I feel that bag is very much stabilized. Rhexis was small, so I wanted to enlarge the rhexis. Be cautious in such cases. Now look at the force. You should be very slow, and I am literally pulling the capsule onto the opposite side to get it propagated in the right direction. So this way the capsule rhexis is being enlarged and 3-piece IOL is injected and case is completed. This second case of mine, it is a colubomatous case, a congenital cataract, more than 180 degree of subluxation. So rhexis principle being the same. In this case, I wanted to use RC anchor, which is uniplanar scleral fixation device, having a large limb and a short limb and holes on both sides. Make the scleral groove in the center of the subluxation, make the scleral pocket to fix the capsule tension segments, and with the help of railroading technique, this IC anchor is getting inside. Care should be taken that it should not poke the capsule nor it should touch the iris, because these are very long needles. So IC anchor is getting inside, so it is very easy to handle, going to 2.8 to 3 millimeter of incisions. So long limbs to be placed into the bag, short limbs on the anterior capsule, and you can see how nicely bag is getting pulled and getting stabilized. And this of the surgery, as cataract is very soft, is like routine surgery. Only eye was suffice in this case, and again IOL is injected and case is closed. This is third case. The case is same, only approach was different. The fixation was with the Sioni's ring. Gore-Tex suture is fixing the Sioni ring. Only single suture was taken. With the help of reloading technique, it is taken out at the middle of the pocket and bag is getting fixed. This is fourth case where there is a more than 180 degree of subluxation. It is traumatic cataract. I approach this case slightly differently. Only mistake I have done, I have not plugged this area before the starting the case with the higher grade of viscoelastics. So confirming the vitreous inside into the AC, vitrectomy is getting done. Again, principle of rexis is the same. Small rexis is done. Later on, I have increased that rexis. So scleral, capsular hook is a mainstem. I wanted to use the Gupta segment intraoperatively to fix the bag temporarily in this case. I used iris hook to get it done, and intraoperatively I have fixed this bag with the Gupta segments. Lensectomy with vitrector done, as rexis was very small. Now rexis is enlarged and soft cataract is getting removed by the phacoemulsification. Actually, we can take out this Gupta segment, prefix it with the needle, but as things were going in right direction, I wanted to use the same ring inside. So loaded on the 26 number needle, 90 polypropylene sutures are taken out in the middle of the scleral wound, and bag is getting fixed, and 3-piece IOL is injected. This case number 5 showing some complications. This is again a traumatic cataract around 180 degree of subluxation, confirmation of the vitreous with the tricot, vitrectomy is getting done, slow motion phaco, capsular support with the capsular hook. You can see the polarized bag, trying to stabilize it with the help of CTR, but not succeeded in getting support fully. So I wanted to use a Gupta segment again. These are really long needle, and these are very difficult to take it out from nasal side particularly. You can watch now. These needle are not flexible. It's very difficult to get it out because of nasal bridge. Now watch this moment. The trailing end of the needle has poked the posterior capsule. Now CTR is in, posterior capsule is ruptured, and capsular MS segment is inside, and vitreous is out. Still, I went ahead with the vitrectomy. Vitrectomy is done, and luckily bag got stabilized. So 3-piece IOL is injected and case is completed. This is completion of surgery. So what precaution we should do in such cases? We just support this needle with the help of blunt instrument like this. So needle is getting in, and you just support this needle with the help of any blunt instrument through the side port. and you can take out this needle very easily to avoid the complications. This is another case. In this case, Hoffman pocket is being created. Again, the needle were used to guide the CT segments. So friends, to summarize, always start the rexis away from the area of luxation. Leading edge of any fixation devices to go towards the area of dialysis. Implant CTR as late as you can, but as early as you must. Scleral glue or Hoffman's pocket to be taken at the center of the subluxation, and always keep all the necessary devices ready in the OT and use the right device at the right time. Thank you.
Thank you, Dr. Sirish Thorat. That was a wonderful video presentation of multiple cases of subluxated cataract. What you showed us is that, in today's day, there is no need to avoid phacoemulsification in these type of patients. They should also get the benefit of phaco, and also an easy way to do it so patiently, so nicely. The most important tip that he has given is that we should have all the segments, the hooks, the rings in our OT ready at any given time to deal with subluxated cataracts. Thank you for the wonderful videos and the wonderful tips.
Yes.
Anybody else would like to say anything or add? Thank you, Sirish. Thank you so much. We now have Padma Shri Dr. Tatyarav Lahane sir. As we all know that he has done a large number of cataracts, and with the advent of phaco machines and good affordable phaco machines and affordable lenses, we had patients of all walks of life walking to us. But even in today's day, and especially after COVID, there was for 1 or 2 years a surge of cataracts which were hypermature or Morgangian, and it could be still done, which is what sir will be showing us.
Good afternoon, everybody. Thank you, Ragini, Sirish, and
So sir has been a teacher to all three of us.
And thank you everybody for supporting me for the election also. See, when you are considering the white cataract, so in that there are some challenges, and challenges are the absence of the fundal glow, extension of the rexis, then the posterior capsular rupture, nucleus drop, the endothelial damage, and then lastly the lens is decentrated. So then use the trypan blue when you are operating. Then the extension, use the forceps, or you can, if you are unable to that, then change it to the can opener and go for SICS. Then the posterior vitrectomy, if it is there, then you will have to go with the 3-piece IOL with the iris claw. Nuclear drop, call your friend. The visco, to avoid the endothelial damage, use visco minimum twice when you are operating. And when there is a decentered IOL, rotate, but don't rotate on second day, wait for 2 weeks and then rotate. So now this is the case, and you can see the white cataract, which is, you can see in the center there is a fibrosis seen. Now when there is a fibrosis in the center and you have stained and operating, so now see, I am going in the mid periphery. So don't can say open in the center, because in the center the force of the fluid is much more and you get the Argentinian flap. Now see, I am doing with the needle. When I am doing with the needle, so that goes in the periphery. So now I am doing with the forceps, so control is much more. So but here I am just recatching and recatching, not doing in a one go. Still see here now, I have recast, still it has gone in the periphery, because the fibrosis of the capsule was there, and so it has gone there. So now you can see the nucleus is saluting. It means once you are doing this, see here, so now there is no buttress, and so whenever you are doing, so you will have to chop. How? See here, this is a sandwich like thing. It means nothing is there, so you will have to see the tip and the chop. So my chopper is a non-sharp at the tip, see here, and then I am removing this. As you know, this again you will see this tip here, see tip slightly downward and then sandwich in between two. So once you sandwich in between two, that is called as a horizontal chop, and in that you can definitely make the pieces when there is no support. When last piece is there, here we are always in the, can say, flight, in the Phaco means flight, and so you go fast and that tears the PC. So Phaco is not a fast procedure, but Phaco is a safe procedure. So don't go fast in Phaco. Now see here, you can see the fluid. You can see the fluid here, and once you see the fluid, then you must know how to go ahead to do the rexis. See here. So if you are going in the, can you see I am going in the slightly peripheral part, can you see this? Not in the center, open I have done in the peripheral part and then doing the rexis. So whenever I am doing the rexis, you should be very conscious, because if the rexis is not complete, then you can't do the Phaco. Again you will see I am trying to do the rexis here, again you will see I am trying to do the rexis, but not happening. So what I did, I took a forceps and you will see there is a eccentric rexis, not in the center. After doing Phaco, you can do, if you want, in the this one, and here you will see it was seen like white, but behind that white fluid there is a yellowish brown cataract. It means it is a harder one, and so now I am here using the sharp chopper. You see this, I am doing the trench, but as there is no support, so trench is not happening. So again you will see this, I have separated, and whenever you are separating, keep it up to the center. Now when the Phaco tip is going, it should go slightly down, not straight. If your Phaco tip is going straight, you can't do Phacoemulsification. So always remember, see here, tip slightly slanting down. When that is a slanting down, it will enter in the substance of the nucleus. It may be very hard nucleus. So that is a stroke length, see here. And once that enters inside, I always see here, again see, my Phaco tip, see, it is not horizontal, it is slightly slanting, can you see this? And then I am making the pieces. So it means my Phaco tip is buried inside the nuclear substance, and this is a hard substance, so it remains inside. It is not a soft. So it remains inside, and then that you act as a support. So that will support your chopper, and once that will support your chopper, then you can do it. See here. Now you have completed the case. Now again you will see another case. You will see here. Once you see the case, it is a, you can say, milky white. It means this cataract is a soft cataract. It is not an, can say, but this fluid occludes, see here, it occludes your vision whenever you are doing the rexis, and there you have always a problem. So wait and aspirate the fluid, aspirate the fluid. So once you aspirate and then use the forceps. So what happens, we never aspirate it, and because of that the problem comes. See here. So I aspirated and came out, and after that, see, I am doing the Phacoemulsification. See here, the nucleus you will see it is moving because no support. So again what I am doing is, can you see this? I am supporting it with the Phaco tip. So here, the embedding the Phaco tip in the substance, see here, of the nucleus and chopping. So once again you will see, embed it and chop it, horizontal chopping, or you can modify it horizontal to vertical, say again, and then separate it. It means the nucleus here you will not use the support of PC. If you use the support of PC, then that will tear definitely. And so nucleus should be above the PC, above the PC. And once it is there, then you can definitely do it. See here another hypermature cataract, you will see here, I am doing the rexis by the forceps. Can you see this? So again see here, the rexis, what I have done is, I have done in the center. Now, once I have done in the center, then that flap which is in the center, that will extend and you will get the Argentinian flap. Why it has happened? Because I was not concentrating, and then I will try to do catch this and catch that. Don't do that. Cut it. I have cut it and again I have cut it. Now I am doing the phaco. You just see the flap near my chopper. It is called as flap. It is called as flap rotating sign. That motility sign of the flap. See here. It is a Rohit. He is on phone also here asking me to come there. So here you will see that motility sign. Always remember, if that flap is moving, go for phaco. If that flap is not moving, don't go for phaco. It means you have teared the PC. So whenever you are doing, look, you must see the flap moving, flap moving. If that flap is not moving, stop, because you have teared the PC. So instead of inviting the retina surgeon, you yourself control yourself. If you control, then there is no problem. So phaco is complete because of the anterior flap motility sign. If that sign is absent, don't go for phaco. If that sign is present, go for phaco, and otherwise you, now this is the, what I want to tell. See the sleeve, see the sleeve of the, you can say this sleeve, it is a transparent sleeve. The same surgeon, this is me only, and see, I told you to go down, the tip of the, my phaco is down, not penetrating inside. I am trying to penetrate, but not penetrating. Can you see? No buttress, no support, and I am penetrating inside. What is happening? It is not penetrating inside. See here. And I am trying to remove that. Okay, I am going to do phaco. You know, this is a white cataract, and see it is moving. Now once the cataract is moving and you are operating, what will happen? How many, see here, how many circles that is taking, so many things happens in the ventricle of your heart. So you will get the flutter. So this flutter, see here, this flutter, can you see the flutter? Your age is reduced by 1 month. 100% age is reduced. So SIC age is better than phaco. So in such cases, don't take such type of risk that I am a phaco surgeon. No. So don't do that. Now see here, this sleeve is changed. Can you see this sleeve? It is white. Another phaco. Another phaco. So why it was not happened? Stroke length of that phaco was less, and because of that it was not penetrating inside the substance of the nucleus. And so whenever you are purchasing, you must know the, you can say the stroke length. See here now again, only I want to see you, the tip is slightly downward and it enters in the substance, and once it enters in the substance, then only we can do such type of phacoemulsification. Can you see this? And the last piece, you must remember, if this is the last piece, you should not do it fast. Otherwise what happens? We have completed the, you can say phaco, and then you feel, yes, I have completed the phaco, and then you will go ahead and so the okay. Now you see the when I am doing the phacoemulsification, can you see this? And it is a brownish in color. So when it is a brownish in color, see my chopper. When my chopper is going in the periphery, see the capsule. I am going below the capsule. I am going below the capsule. Normally why you get the tear? Because you tear anterior capsule while chopping. and then because of that the posterior capsule is teared. So, and that why it happens? Because cataract is brown and you will not see the capsule. You will not see the capsule. So, always you stain the capsule. Now, the stain you will see how we stain. Our stain is like that. We stain the capsule, just put a stain and then remove the stain. Always remember, to stain the capsule it requires 17 seconds. But in the white cataract or in the brown cataract, in the pediatric cataract, the stain should be there for more than 1 minute. Why? It will not only stain, but it will help you for the tear and can say the sear. So, both places it will help for the rhexis. That capsule is more fragile. So, do it for 1 minute. So, the phaco whenever you are doing, it should give good result and not fast result. So, for the good result, you wait, and once you wait, then you can go ahead and do the. So, when you are doing the hard cataract, can you see this? I am doing the rhexis. Always remember, when you are doing the rhexis should be larger. Rhexis should be larger. If the rhexis is smaller, then you can't do the phaco. Why? Because the superior portion, that is a anterior capsule is open, so it will open like this. If not, then it will be like this and the posterior capsule get teared. Why? Because anterior capsule opening was smaller. The posterior capsule has teared because of the small rhexis. So, if the rhexis is small, so increase the rhexis and then go for the phacoemulsification. Otherwise, you will have a posterior capsular tear. So, that will be the problem whenever you are doing such type of cataract. And you see this is the cataract and I completed it. So, now see this is a direct chop I am just showing you, and you see the parameters also here. So, here you will see I am doing the direct chop. Can you see the tip of this is going inside and then up to the center I am making the piece. See again, my tip is going down and the chopper is separating the. So, chop is possible here. Why? Because there is a whitish element in the cataract. If it is blackish element, stop and chop is better than the chop. So, if it is black, don't go for the chop, go for the stop and chop. So, that is what is required. Hello. So, basically the when such type of you can see it is completed, and can you see this fibrous capsule? Can you see capsule is fibrous, and when see now chopping, can you see this chopping? So, here again you will see very slowly I am going inside and making the pieces. It means unless and until you hold the nucleus, don't try to divide. First hold, see here, and once you hold, then take your two instruments on both the sides. So, again you will see here, I will show you. Can you see this? So, it goes inside, and when it goes inside, then I will make the piece, and once that piece is made, then the I will come out, see here, I will come out, and then it is completed. It means whenever you are doing the phacoemulsification, important thing is that where is your tip is very important. And you see here now, if the tip is in, then your chopper is work. Why? Because this hold will help the chopper to separate it. If it is not hold properly, it will slip. The chopper and nucleus will slip. And so, to avoid that, you will have to catch it properly. So this is what? Now this is, you will see the another cataract. Can you see this is completely hypermature cataract? Can you see this? The small nucleus, and you can see the capsule I have stained, but this capsule is having the fibrosis, calcification. And now this, can I do anything? No. Now see, what I am doing, I am cutting it, my another, see here, supporting the, see here, I am supported by the, you can say, other instrument, and I am trying to do by the forceps, but it is not happening. I cut it. So I cut it by the scissor. Now what I have done, I have cut the capsule, but as it is a fibrous capsule, and now you will see the nucleus. Are you going to do phaco in this? Never. Never, because this will invite everything. So better if you can go for SICS, go. If not, then you just put a scaffold. Put a scaffold. Before doing anything, when we put a scaffold, when our fingers are burned, then we put a scaffold. Don't do that. Before finger burn, put a scaffold, and then you see here. And once there is a this IOL behind, then it is possible to do the phacoemulsification in such type of cases. So here you will see, so I have completed the phacoemulsification, and the only thing is that whatever works better in your hand, whatever works better in your hand. It is not that I am showing you, so you should do it. No. Whatever works better in hand, only you can have a tips from the video. The tips will help you, and not my technique. It should be your technique, and the whatever I have shown you is a, you can say this. Ragini madam, as I have to go to the other hall, they are calling me. I will present my another presentation, and that is a IOL exchange. Okay.
Yes, sir. Yes, sir. Please go ahead. Sir, your first talk was very excellent, and you are sure of different cases. So, what I learned from these all teaching videos, that while dealing with the Morganian cataract, you should decrease your intralenticular pressure first before going for the complete axis. Use both needle and the forceps to get it complete, or you can take help of forceps to get rid of fibrous capsule. Last piece to be removed with the epinuclear mode, and flap motility sign is very important. If flap is moving upwards, then you are sure that it is not gone in toward the posterior capsules. And staining in such cases is really important. You should stain it for a minute, and the sign is, if your side port is got stained, the capsule is stained properly. So, sir, thank you very much, sir.
Thank you. Thank you very much. So what he told is very true. And now I will show you the few things why this happens. Why this happens? Because whenever you are loading the lens, that time you have made a cataract complete, and after that you feel, yes, I can do anything. And then loading is not proper, and the lens, the one of the loop or haptic breaks. Why? Because you were in the, you can say, so much of the haste, and see I am cutting the lens. This lens I am cutting, and once the lens is cutting, use visco, because second day patient will be unable to say anything, and then it is very difficult to answer that there is a ear, there is that. So and now iris is coming out. So this is going to happen. One complication is supported by other complication. One complication doesn't happen. It happens two complications together. So like this. So I have completed it. Now this is the I think patient. This is the patient, the 15 years old patient, having the, can say, -9 myopia, and this patient want to remove of this one, and here as it was very old, so I have started my old technique of the they can say this, and here I am trying to separate out the lens, see here, again fibrous lens, going all type of thing going here and there, and lastly I was able to remove. But when I have removed, I have seen there is a PC, tear. So I have gone to the PMMA lens. This is PMMA lens, one piece. So we are always concerned with the, can say bifocal, trifocal, all others. But what is shape is very important. So I have done the, you can see the vitrectomy also, and I have implanted the lens, which is a monofocal lens, and patient is very happy. It means if the patient was having -9, second day patient is having nothing. So he can see without a glass, so he is happy. It means it is, he will not ask me monofocal and trifocal. He will say, my spect has gone. So that is what happens whenever you are doing such type of things. Now another thing is this IOL exchange. See here, I am doing the, can say the, 5 minutes में पहुंच रहा हूँ. हाँ. So now see, I have only loaded. It is not some other person. And what has happened? The can you see this? The haptic is broken. Why? Because I was very confident. I have done everything. And see now, can you see the haptic? So keep that haptic on the other side. Keep that haptic on the opposite side. And now cut, very small cut is required. Very small cut. It is not full cut is required. See here. Can you see the, I have cut the lens very small. And then once you have cut this small cut there, then bring the lens, can you see, loop outside, and I want everybody to see here, rotate it, see here, you can see the cut is there on your side, and I am rotating, can you see this, rotate gradually, so it has stuck near the cornea, and once you rotate, see here, gradually on your right side, you rotate, or if you are lefty on left, can you see, and the lens has come out. I have not extended anything, but small cut that can help you, and then the, can see this again I will showing you, can you see this, and lens has come out. So it is possible, so broken haptic on that side, and then you cut near the here haptic, and then you bring it gradually by the circle, and it will come out. So this is what conclusion is, IOL exchange can lead to endothelial cell loss, and the so whenever such, if you are done the specular count, good, if not, forget. 5 minutes में पहुंच रहा हूँ, ऊपर निकल गया हूँ, 5 minutes. The combination of the cohesive and dispersive visco, so use combination. What is happen? Once you go inside the, we can say anterior chamber with phaco, you tell me how many of you, they come out of the half of the surgery, half remained, and put visco. Just raise the hand. How many they come out? 1. So in the 3, 4, 5, 6, 7. Now in, you can say this hall, there may be, you can say more than 300 phaco surgeons. Out of that, 9 people are coming out. It means 291 people are not coming out. Why? Because they are in Rajdhani Express. Once they enter, finish. So don't do that. Whenever you are doing a phaco, which is a mature cataract or a nuclear cataract, always, after doing half of the cataract, there should be one break, come out, put visco, and again do it. That will reduce your problems on the second day. Patient will not ask you कि मुझे नहीं दिख रहा है. And so, if you do that, second day your cornea will be transparent and patient is happy. Why? Because just change in one step, that you stopped in between and put the visco. Otherwise that 3 ml visco you are going to throw only. Why not to use? But because we are a very fast surgeon, and secondly we are, you can say the direct, you can say express, so don't be express in phaco. You can say you can have a, you can say, small railway-like thing where there are so many stations are coming. So be one station, and next time you tell me, you will be very happy on second day. So one station of visco. So half nucleus removed, one station of visco. Whenever you are implanting the nucleus, this lens, see properly, the click sign comes. When it comes, it is inside the, you can say, injector. If it is not coming, then you have just forced it, and then you are putting, because of that it has teared. So it means, if you do it properly, it will happen. And I have seen all the people, the new generation, the old generations, they are doing very, very good phaco. So I appreciate the your expertise, and I am very proud of ophthalmologists in India. So they are doing very good work. Thank you very much, and thank you, Ragini ma'am, for allowing me both the presentations. And now I think you can go ahead with that, and excuse me, because there is one OPL going on, and in that I am going to show them some different type of video. Thank you very much. Thank you very much for attending.
Thank you, sir. IOL exchange is not very easy. What we have seen, it is with the experience hand. And most important, what you have shown is a partial cut and remove through the small. This is a very unique idea. Thank you, sir.
Our next speaker is Dr. Navneet Toshniwal.
Dr. Navneet Toshniwal is the next speaker. Excellent phacosurgeon from Solapur. Secondly, excellent teacher. He had 2 books on his name. And if you see the phaco, what he tips of the phaco, and you just see him, because that is practically what are the problems arise, he will share with you. Navneet, go ahead.
Thank you, sir. Thank you, Lane sir, who is my guru. Thank you, Ragini madam, for having me in this course. It's a video. Already, sir has covered the Morgangian, but what I am going to tell you, the white cataract tips and tricks. Every white cataract is a different. Stop and chop to start with. What Ragini madam has shown, that in a soft cataract also you have to start with stop and chop. So you have divided the nucleus with the phaco tip and chopper, and you can see the simple vertical chops in the back, because this is an adequate hard nucleus, and what sir has emphasized, the go into the nucleus and then chopping is very easy. One piece is over, second piece will move nicely, give a good position, embed the mask perfectly, and you can see the simple vertical chop in the back because of the adequate hardness. And the last pieces, you have to go in a supracapsular plane. This is another case. When you start with any white cataract, don't be overconfident. Every case is different. You don't know what is exactly the hardness and all that. You can presume, but reality when you start. That is the reason I start with stop and chop. It's a wide groove. This is the Toshniwal pre-chopper. You divide it equal pressure on a 2 half of the nucleus. So there will be the less zonular stretch. And then every half we have to lift at the plane of the capsule. So now these are the horizontal chops. If you try to do in the bag may be weak because it is a white cataract. You don't know the degeneration of the capsule. So at the plane of the iris or at the plane of the capsule, you can do this horizontal chop. Another piece automatically, when the space is there, with the vacuum and flow rate, piece will come towards you. No need to move toward the piece and the remaining chops. When you do these cases, as sir has emphasized, the viscoelastic, they are the must. Very important. Take a break and put it. This was a small pupil, shallow SC and mature cataract. So I was not interested to put dilatation before on table. I have put the dilatation, very important products are in the market. And then I started with the capsular axis. Sir has mentioned many tips. So this is a very important, use directly. I am using the forceps. This is the microcapsular axis forceps. Do it in a small, but you have to see the edges. If edges are not curvilinear, you have to check, and even this small edge, you have to remove with the forceps and then aspirate, so the intra-back pressure will be reduced and you can do. See, this is a micro scissor, again a microrhexis forceps. So what is the important thing when you want to tackle these cataracts, because these are the experienced surgeon, but for us we have to take the good instruments. So microrhexis forceps, micro scissor, they will help for these cataracts. Again the same thing, stop and chop technique. Hardness you will understand in a 1 or 2 stroke. This I have mentioned in my first book. You should feel the trench so that you will get the correct idea of the hardness of the nucleus. This is again a pre-chopper, equal pressure, put in the center, go in the deep in the groove. These instruments are now the part and parcel of our phacosurgery. And again, when you confirmation of the division is the very important. See, it is stuck at one point and chopper is there to help you. Engage the piece and complete the division. So division, just division is not important. Confirmation of the division, then the rest of the things are easy. And if you see here, I don't use chopper more. It is the one phaco handpiece in the center or just near. Here you can see, just dislodge the piece, but again go with the certain principle. Don't push the piece directly from the convex end towards the center. That is many times what we are doing. Go to give the correct position to the piece, whatever it may be, half hemisphere or anything, and again bring at the level of rhexis. Another very important point in this situation, that piece should not be stay vertical. Keep it horizontal with your phaco tip only. Now here I started the capsulorhexis. Suddenly it went away. I catch, I completed, but I see another tag and I tried to complete it. This is what already I mentioned. So these instruments are very, very important. Decrease the intra-back pressure. When you are talking about the tips and tricks in a white cataract, most important is the capsulorhexis, because unless and until we do the complete capsulorhexis, we cannot move. These are the very, very simple instruments and not very costly, but one has to do the practice. Why I am telling you, with the needle, you have to push the capsule. With this forceps, you have to pull the capsule. So this push and pull is important. So pull technique is very important. What the sir has mentioned rightly, that no ego. This was my video of 6-7 years before. I was not having the very good knowledge of the depth of the trench. I could not divide it. In those days, immediately, and this is the learning from my father, don't do overconfidently anything. So I trying to convert it a very simple way, just extend, because I am doing my all the cases till today limbal incision. So very easy to convert. I don't do the clear corneal. So it is very easy for me to convert the case. Here you have to take precaution. This small size of capsulorhexis is not needed. You have to cut it. So most important is your incision part, crescent, keratometry, and in those days I was using this our Vanna scissor to cut the capsule at the 2 proper point and maybe 1 inferior. As many as points, no problem, according to the hardness of the nucleus. And just lift it out. I never see what is the size of the incision and all that. It should come out smoothly without damaging to the PC or cornea. So nucleus is out. You can remove it. And then I saw that posterior capsule. You can see here the posterior capsule when I was touching with the visco cannula. It was so fragile. So that was a great decision. Otherwise, nucleus might have gone into the vitreous. So no ego for these cases. You should be ready with the many tools. But finally, you can be ready to convert these cases. This is a simple 3-piece PMMA lens for this purpose. So finally, white cataracts are different many tips are there, tricks are there. You have to go accordingly. Thank you very much for your patience hearing. Thank you, Ragini madam.
Wonderful presentation, Dr. Navneet sir. Sir, one question to you. You have, do you the same chopper for everything, or do you have some different choppers for different cases as far as hardness of nucleus is concerned?
You mean to say pre-chopper?
No, chopper.
Chopper I am using, very good question, sir. This
your-
is all the time confusion. When there is a hard cataract, you should use sharp, long. Everything is correct. But believe me, in chopping, hold is most important. If you hold perfectly, any chopper, any simple chopper will chop, sir. In all the grades of cataract, this is my perception. Thank you.
Thank you, sir. Because these are all horizontal chopping techniques, and you have, I mean, chopped it very nicely with even with the blunt chopper.
Yes, thank you, sir.
Thank you, Navneet, for the wonderful presentation. Thank you, friends, for being here. This is the last presentation which will be showing the posterior capsular tear. So this is one of the dreaded complications that we all know and we all fear from our first year in residency. So this was a hyper-mature cataract, and as you can see, there is a lot of movement, and you are doing phacoemulsification, and now you are doing the cortex aspiration. So the cataract has come out peacefully, and we are doing the manual irrigation aspiration with the AC maintainer and the single port cannula. So here you feel that the cataract has come out very nicely, and you go ahead with this. As you can see over here that the phacoemulsification has been complete and you are relaxed, but what has happened is while doing the aspiration of cortex, there was a PC tear. So what do? Either you leave it like this, luckily there is no vitreous prolapse, but this is now converted with viscoelastic into a PCC, so that the flap won't trouble you, and a central PCC has been done. Use of viscoelastic is very, very important, and in this case the IOL in the bag is possible. This is the first case again where we do phacoemulsification. Here we are doing a stop and chop. This is a reasonably soft cataract, and we go ahead with the phacoemulsification. As you can see, what you see while you are finishing surgery is you can see this movement, and you know that what has happened is that while doing phacoemulsification, you have left the safe zone, ventured slightly into the periphery, and as you can see now, there was this moment where there was a slight hole and you went deeper and the PC tore. So what you do is there is cortex, but the vitreous will interfere, so a vitrectomy is done and then the IOL is put. So never go too deep into the trench of the soft cataract was the lesson that we learned there, and not to leave the safe area within the rexes. This is a posterior polar cataract when we start surgery, and to do small multiple points of hydro procedure, which will be hydrodelineation. Now in these cataracts, even though you see them on slit lamp, and we do not have OCTs to see whether there was a frank dehiscence or a defect, you go slowly, multiple points of hydro procedure. The cataract is extremely soft, and as you can see, there is a crater effect. So it is difficult to divide. There is a crater or a saucer formation, and the pupil is very, very small. Phenocaine can be used now to dilate the pupil and to see where we are. So what you do is to lift one of the pieces, because there was no other option left, and to try and rotate the epinucleus with the cortex that is remaining. The pupil is slightly dilated. This is the epinucleus mode in which the cataract is being done. So whether there was a dehiscence, whether there was a defect, which by our parameters increased, we do not know, but there was a PC tear. So again, all anterior segment surgeons need to have a vitrectomy standby to learn this anterior vitrectomy, because this is something that we to do it ourselves. Use tricot to stain and completely remove whatever vitreous is there. and then to put the IOL in the bag. Now a good rhexis, the absence of vitreous, can help us to put this inside the bag, and once it is safe inside the bag. Now here this is a mature cataract where we are trying to do phacoemulsification. There is no epinuclear buttress. This is completely mobile, it's now vertical, and there is no hold over the nucleus, and you are trying to do phacoemulsification. Now at any given point, this is a iris above, supra iris plane phaco, where you need more viscoelastic, and as you can see over here, this was a hyper mature cataract with the capsule, which is given away because anyway you are quite, not really happy with the way things are going, and you yourself are uncomfortable when the nucleus is in the anterior chamber. So in this case, to try to do anything further would be difficult. The nucleus will go in. So this IOL scaffold, which is invented by Dr. Amar Agarwal sir, is a good and a safe option, because this IOL then prevents this nucleus from falling down. Because once a nucleus falls down, then nothing is in your hands. What you have to do is now just transfer the case to the vitreous surgeon. But here with the IOL scaffold and the nucleus in the anterior chamber, you can do a phacoemulsification. What you have to be careful about is protecting the endothelium, which is not a very small thing, because if the endothelium becomes hazy or there are SKs the next day, the patient is going to question you. And even if you do not have anything in the second day, you know for sure that some amount of endothelium has been lost. But here you can do a case comfortably, and you can give good results. So posterior capsular tear can occur at any time in your practice while doing surgery. It can, like from the time I was doing residency, what I was always scared about was a PC tear. And what sir said is that whenever something like this happens, it's better to take a moment to put visco, to think where we stand, how we can go ahead, because if you panic, then you are going to make the situation worse. So PC tear can occur at any time, but to handle it, whether we can go ahead, whether there are any nucleus pieces in the vitreous, whether we can go ahead, whether it needs an extension, needs a lot of thought and care, removal of the vitreous completely, and to give the results that the patient desire is very, very important. So once again, I would like to thank all of you for being here for the case presentation, and I hope that you enjoyed a complete video presentation of wonderful cases. If anybody would like to add and give us tips, they are all welcome. If any questions are there, they are all welcome too. And I thank you all for being here for this course and being with us today. Thank you, Shirish, for the lovely cases with coloboma. Thank you, Dr. Navneet, for the mature cataract, and of course Dr. Lahane sir for his tips and his teachings as always with the more ganglion cataract and with the IOL exchange. Thank you so much. I thank all the seniors and friends who are here today for this course. Thank you everybody. Thank you so much.
Thank you, ma'am, for the wonderful presentation. If I may ask a question, ma'am, which please excuse my voice, I'm having laryngitis. Which scissors are you using? Like, is it epsilon, micro scissors?
To cut the IOL?
Yes.
Yes. So there are special scissors available. We use micro scissors to cut the IOL. If you do not have anything, you have to be just careful that your scissors which you have in the OT, the extension scissors, the corneal extension scissors, are sharp enough to cut the IOL. But it is better.
Rhexis, where there is fibrosis.
Rhexis forceps would be very tiny to cut the IOL, and that would not do the job. So you should, like we have CTR rings or iris hooks, it's better to have one more forceps. What we do is when we are doing surgeries, we have these special instruments also autoclaved with us as a standby.
Madam, special IOL cutting scissors.
Special
IOL cutting scissors are available. Okay. Even sharp and long manas are available for cutting of the IOLs.
So not for cutting IOLs. I wanted to ask for capsule.
Capsule. Okay, so micro scissors, we have no financial interest, but micro scissors which are available from Epsilon is something that we use, and these are very, very good, because if you do pediatric cataracts, then the capsule is very elastic. But even in patients where you are worried about getting a Argentinian flap, to use a good viscoelastic and use these micro scissors is extremely helpful, because the first thing that I learned in phacoemulsification is break the rexes and you break the commitment to phaco. So micro scissors, leaving around aside the finance of the micro scissors, it is a good thing to have in your OT. May not be in every set because then they are very expensive, but you can autoclave these scissors or IOL cutting scissors, or have this as standby for every case that you do.
Thank you, ma'am, for teaching us ABC of phaco. Thank you so much.
All are phaco surgeons and beautiful phaco surgeons. These are our tips and something that we are given an opportunity to present. I think in today's day, phaco surgery is a part of everybody's life, even if you are super LASIK surgeons like Rupal ma'am, who's sitting here. So I think cataract is something that we all have to do to remove the cataract blindness in India today.
Thank you so much.
Thank you so much.
Thank you, sir.
Thank you.
Thank you very much. Yeah.
Can you come to the mic, please, dear?
Yes. How you? Madam, if zonular, zonular weakness is progressive, like in cases of pseudo exfoliation, so you should fix the IOL with the iris claw or scleral fixation. If the subluxation is stable, like in cases of traumatic cataract, some penile cataract, in that cases you need to fix the bag.
I wanted to ask this question after your cases, like the cases which were the cases which had a very high grade of subluxation. You have still gone ahead and done the fixation with the Sione ring segments or whatever. Wouldn't it be easier to just do a scleral fixated this thing or an iris claw? So that is what I wanted the decision making.
In my practice, I see to it that the bag should be preserved. And believe me, more than 120, 160 degrees of subluxation can get stabilized. You just do it once, you will do it forever.
So I can, if it's okay, I can answer this question. See, putting an IOL physiologically inside the bag, that is the best thing that you would want to. We've been putting monofocal IOLs in patients in the bag, and Indian monofocals where patients are 6'6" and even N6, which is very, very surprising. So when you are putting an iris claw lens supported by the iris, though everything appears good, there is always a chance of cystoid macular edema. You are using the scleral fixation, and there is something from the interior of the eye to the exterior. So without taking any risk, if you think that the subluxation is such that the bag, like Dr. Sirish said, can be stabilized by Sione's rings or segments, and you can put the IOL safely in the bag without the whole thing subluxating or dislocating downwards, then that would be a better option, though the iris claw and all would look easier. So, and having said that, what you are saying is correct, that we've found cases where we've had patients referred to us with so many things inside the vitreous, including 1 or 2 lenses and 1 or 2 rings also. So everything has to be customized, but it can be done, and before thinking that no, it cannot be done, we can try this for the patient.
Thank you very much, ma'am and sir.
Yes. Sirish, and yes, ma'am.
Ma'am, I want to know what are the precautions we should take in case of very shallow, in phacoemulsification in very shallow AC.
So very shallow ACs are a part and parcel of our lives. You see some people who are very hypermetropic with small eyes. So use of a good viscoelastic, and when you go in, you have to, supposing when you go in, and if the tunnel should be correct. If your tunnel is big, it is leaky and the fluid leaks out, the anterior chamber would shallow even more. So before you go in, you should not use too much of flow of fluid, and once you enter the anterior chamber, you can press on the flow also, and use of a good viscoelastic which will form the anterior chamber, and try not to come out, because in patients who are on medications for prostate, there will be IFIS and there will be the iris coming out. So use of a good viscoelastic, because the space is very narrow and you would like, there would be SKs also, plus it would be difficult to operate. And most of these patients with shallow anterior chambers also have very myotic pupils and undilating pupils, which adds to the problem of the shallow AC.
Sometimes iris is coming through the tunnel. All
Yes.
the time you have to push visco
Yes,
again.
so what you have to do is once you go in, do not start the flow and go in, make the tunnel the correct size so that the fluid and the iris do not come out. Use viscoelastic and go in, then start the fluid and try not to come out. If you have to wait, like sir said that it's not bad to come out, but just to wait with visco, put visco through a side port and another instrument through the side port to manage the iris, which would be a little comfortable.
Thank you.
Thank you. Thank you, friends. I think our time ends here
Yes,
too.
ma'am.
Thank you so much, everybody. Sir is not there, but we can have a group photo, the three of us.